Hi, I'm Dr. Galit Talmor.
And I'm Dr. Rafi Romano.
And the subject we're going to address is space dentition. We would like to share with you several cases in which we decide to resolve the case in different aspects.
Either orthodontically, as of course some of you would choose to close spaces,
or prosthodontically, or a combination between the two of them.
And I think we will surprise you in some cases where the obvious solution will be orthodontics or prosthodontics, and we decided, because of the discussion between the two of us, to choose something which was very creative. We hope you'll enjoy it. The next case is again a case of orthodontics only, but we got some relapse, and the relapse in a way was quite expected, even not wanted. This patient, as you can see, is a typical mild class 3 malocclusion. You can see she has a very small maxilla retruded, she has prominent chin, she has a very typical situation that if I expect when I will open her mouth, which you can see here, she will have a little class 3 malocclusion. You can see she has some crossbite, some edge-to-edge contacts, which of course we can choose between doing an orthosurgery when she will be 18 and more, or do a fine compromise where we can tilt a little bit the upper incisor forward, we can tilt a little bit the lower incisor in, and create a nice overjet. The main problem here is that when we finish the treatment, when the patient is around 14, 15, in a class 3 malocclusion, we know that there will be additional growth until the patient, sometimes even if it is a girl, can be until the age of 20 years old. And then even that you have a very nice overjet here, a positive overjet, which allow us to do fixed retainer, a nice result, we expect to have some relapse. And here she comes after 5 years of post retention, and some space was open between the two centrals. Okay, so the mother and the patient comes to me and say, we need to close the space now. And I tell them, no way, I don't want to do it orthodontically, because I know why the space was open. The lower jaw grew a little bit and then pushed these two centrals until they, even with a fixed retainer, they just a little bit moved and migrated forward, and a little space was open. Now, if we will force this tooth in and try to close the space, then we will get to a point where the overjet is minimum or even negative, and then first of all we will create trauma to the teeth, and second, the gap will continue to open, or we'll get some root resorption. And this is why I referred to Galit, in order to try to keep this situation, which is now stable for the patient, this little gap, and try to build the composite there and leave it as it is.
So what can we offer for this kind of patient in this situation? Well, this patient must understand that this is only a compensatory result. I can work with the situation that I have. It won't be ideal, but I can improve it. And only after she really realizes it, I can go ahead with the treatment. So what I do usually with this patient, I prepare actually a demonstration for them, some kind of presentation, and I show them all the problems we are about to have. We can show them what are the possible resolutions, but we need to know that we're actually compensating for a problem that still exists, and we cannot know how stable the end result would be. Still, although we know that it is much more stable, this situation is much more stable than the closed spaces are, still we cannot know what will happen in a few years also after my treatment. So what are the problems that we're about to have in a prosthodontically point of view? Well, we know here that, again, there's a kind of a difference in the zenith of the two centrals. We can see that the inclination of the two teeth is a little bit different. As Rafi said, the gaps reopened and we need to close them. The proportion of the teeth, although they're long, they're quite narrow, so maybe in the proportion perspective we were going to be okay with making them a little bit wider. Another problem is that the midline is not corresponding to the midline of the face. The midline of the dental midline is not continuous with the midline of the face, but we're not bothered by this. We know that there can be a deviation of also maybe
until 4
millimeter. It is not visible to the eye, or acceptable to the eye. And by a very simple DSD, we can see that we can reach very nice result, although not optimal, not perfect, but quite reasonable result. And we examine this future to be restoration by a very straightforward mock-up, and after examining this mock-up again in videos, in photos with the mom, I'm used to having another person in the room in order to examine the new look. It helps the patient decide many times. I even put the pictures on the presentation and let them see themselves. I don't know why, but usually I see that when patients see their picture on a screen, they seems to be much more objective, or they seems to have a very reasonable view of the situation. So next we're going to restore directly with composite all the gaps that we saw. We're going to make these teeth a little bit wider, a little bit longer. We cannot make them that longer because we need to remember that there's only a little overjet existing, and I'm doing so by using a premature silicone index. By this silicone index, I build the width of the teeth. I decide upon the final width of the teeth. I'm not using this index in order to decide upon the subgingival area. The subgingival area, when I'm closing the diastema, is being creating in a freehand manner without any index. I'm using, as you can see, a celluloid matrix. I'm pushing the composite subgingivally against a celluloid matrix. There's another method that was described by the Style Italiano group that is called the wing technique, the front wing technique, in which they only build in a freehand manner the buccal aspect, and then they complete the palatal aspect of the restoration while injecting a composite layer at the gingival area and completing the palatal wall up to the up to the contact point of the buccal wall that was pre-built. As you can see here, the end result is very nice and was pleasing both for the patient and for us. The question is, as we said before, is it going to be stable? And we cannot answer this question. We sent this patient back to you, Rafi, in order to have her fixed retainer. She needs to come for a checkup every 4 months, and we have to have her compliance. Without patient compliance, we cannot really have a guaranteed success in these kind of treatment.
I think it is important for me, at least in my clinic, because orthodontics comparing to prosthodontics is, I think, a lifetime job with every patient. Retention and follow-up for me never finishes, and patients, they expect to do boom and finish and forget. That never happen. It will never happen when you paint your hair. It never happen when you do your nails. It will never happen when you buy $500,000 car. It never happened. You need to maintain it, and every person has individual characteristic. The way he masticate, the way he abrades his teeth, he clench. Some people are vegetarian and they eat all day long fresh vegetables, and some people eat a lot of soft food. There are so many factors. Some smoke.
How disciplined you are with wearing your retainer. Some
and I can tell you from our experience, if you have a patient which we will show you in a minute, that is very, very obsessive in doing all the orders as prescribed, then everything looks really good, and every minor change we can immediately monitor it. But if patient disappear, that's a huge problem.
Yeah, that's right. And in my perspective, I think it's important to say that these kind of restoration need our checkups, need a recall every once in a year in order to polish this restoration, and we charge for it. I mean, the patient needs to know that we're charged for it. It's our time, it's our efforts, and these are part of the preliminary treatment plan, actually.
See you in our next series of videos in our YouTube channel. Bye-bye.
Bye.